and he joins us from actually my department at the Palo Medical Foundation as a neurogastroenterologist and motility specialist. Nikhil did his training in Southern California. He's a Bay Area native and came back to the Bay Area to join the motility practice and group at CPMC, where he was, I think, the Associate Director of Neurogastroenterology and Motility. And we were fortunate enough to recruit him to join our group down in Palo Alto. Nik is going to give us a review of many of the important developments in neurogastro and motility in the past year. Thank you, Nik.
Thank you, Eric, and thank you to the Society for having me. So today I'm going to talk about everyone's favorite subject, motility and functional bowel disorders. So I was asked to give a yearly update in motility and functional bowel disorders. So obviously, pretty big spectrum of diseases. So I hopefully combined some higher impact studies and some other studies that I found to be interesting. So the first study we're going to talk about is out of Medical College of Wisconsin, where they looked at daily opioid exposure and its association with dysphagia and manometry findings. So as we all know, opioids have a dramatic effect on the gastrointestinal tract, and that includes its effect on the esophagus. However, the effects on esophageal physiology are not well studied. And this is important because at most manometry sites, up to 10% or more of patients are on chronic opioids. So this was a study where they looked retrospectively at patients who underwent high-resolution manometry. They were classified into opioid naive, occasional opioid use, or daily opioid use, and they used morphine milligram equivalent day dosing. And manometries were interpreted using the ManoView software and the Chicago classification. So they looked at overall 1,890 naive patients versus 224 chronic opioid users. The patients who used occasional opioids were excluded. The most common reason for referral was dysphagia, and the average morphine equivalent dose was 45 milligrams per day, so pretty high dose opioid use. And as you can see, the pressure metrics in the chronic daily opioid uses were higher, but more importantly, these subtypes were found to be more common in the opioid group. So much more achalasia type 3, EGJ outflow obstruction, and esophageal spasm when compared to naive patients. And in addition, unsurprisingly, opioid naive patients were much more likely to have normal peristalsis. So in summary, 10% of patients referred for manometry are on opioids. They're more likely to experience dysphagia. And chronic opioid use is associated with impaired deglutitive LES relaxation and abnormal peristalsis sequence. And this seems to manifest mainly with type 3 achalasia and EGJ outlet obstruction. So briefly, I just wanted to show what that looks like on high-resolution manometry. So this is what a normal wet swallow looks like. You can see the UES opens, and in this patient, they have normal peristalsis. But as you can see with the LES, there's incomplete relaxation and pressurization in the distal esophagus. So this is pretty classic for EGJ outlet obstruction. And in the same patient who's been weaned off opioids, you can see they have that same nice peristaltic pattern, but there's LES relaxation and no more obstruction at the LES. So in summary, in patients who do have dysphagia, I would try to get them off opioids before doing high-resolution manometry. The second study we'll look at is the use of cannabinoids in patients with gastroparesis and related disorders. This is out of Parkman's group in Temple. And so for background, 15% of adults use marijuana regularly. That's probably much higher here in the Bay Area. Marijuana has been shown to have some benefit with chronic pain as well as chemotherapy-induced nausea and vomiting. The two main components of marijuana are THC and CBD, and these activate two endogenous cannabinoid receptors, CB1 and CB2. CB1 is predominantly in the myenteric neurons as well as submucosal neurons, whereas CB2 tends to be on the epithelial lining, and it may be important in both inflammation as well as permeability of the GI lining. THC and CBD both interact with these and other cannabinoid receptors in different ways and depends on also multiple other active components. There's been no studies looking at cannabinoids and gastroparesis. So this was a prospective study in patients that were referred to a motility center for gastroparesis, and they were asked to fill out questionnaires, including GI symptom questionnaires, Rome criteria, as well as complementary and alternative medicine questionnaires. In this group, 78% had delayed gastric emptying, consistent with gastroparesis. In the other 22% of patients who had normal gastric emptying tests, they did meet criteria for either functional dyspepsia or chronic nausea and vomiting syndrome. In this group, 47% used cannabinoids quite regularly, and this was predominantly inhaled marijuana, but also a good proportion were on dronabinol and CBD. It should be noted that during the time of this study in Pennsylvania, medical marijuana was approved, but not recreational. 52% were recommended to use cannabinoids by healthcare practitioners. And the most common reason for using marijuana was nausea. And so as you can see, in both marijuana and CBD, the perception amongst patients was that it was making them mostly better. And in fact, pretty much nobody felt worse or very few unchanged. And the same thing with some of the other complementary things like probiotics, ginger, acupuncture, etc. But when you look at actual symptom data, and I'm sorry if this doesn't project well to the back, but in patients who are receiving cannabinoids, they had much higher symptom data compared to non-cannabinoid users for pretty much all symptoms: nausea, vomiting, fullness, pain, and so forth. And this includes both the GCSI, the Gastroparesis Cardinal Symptom Index subsets, much higher nausea, as well as abdominal pain. So in conclusion for this study, about 50% of patients use cannabinoids quite regularly. Over a third use it on a daily basis. And although they have perceived benefits for nausea and pain, these patients did tend to have much more severe symptoms. And so, I always worry about overlap with hyperemesis cannabis syndrome, and so something to think about when you see patients like this. So I didn't want to be too much of a party pooper, and so I wanted to look at the beer effects on gastrointestinal physiology. So this was a group out of Spain who basically, I think, just wanted to drink beer and validate it. But they looked at beer and its effect on postprandial digestive symptoms. And so beer is thought to be related to both GERD and functional dyspepsia. And so they looked at alcoholic as well as alcohol-free beer compared to mineral water. And they measured dyspepsia and GERD using a nutrient density test and 24-hour pH impedance testing. And in both patients who were taking traditional beer as well as non-alcoholic beer in moderation, which was defined as 2 beers a day, there was no change in GI physiology based on gastroaccommodation or gastroesophageal reflux on impedance testing. So beer in moderation, still good. So I wanted to switch gears a little bit here and go over some systematic reviews for functional bowel. So one of the questions that I always see is probiotics. How effective are they? And is that something you recommend for IBS? And so as you guys know, the data for probiotics is not very good, but this was one where they looked at VSL-3, which is probably one of the most stringently tested probiotics for IBS, and they looked at a systematic review and meta-analysis for this. And so they included these 5 studies. As you can see, they looked at VSL at varying doses and treatment durations, and they measured abdominal pain, stool consistency, overall improvement, and a bunch of other metrics. And as you can see here for abdominal pain, there was no major difference between placebo and VSL-3 across the pooled data. Same thing with stool consistency. There was no major improvement compared to placebo and VSL-3. Bloating as well did not seem to be significant when they looked at pooled data or quality of life. There was a trend for overall improvements with VSL-3, but it was not statistically significant. So in conclusion, there does not seem to be overall improvement in pain, stool consistency, bloating, and quality of life with VSL-3. There was a trend towards improvement in overall response. It should be noted that there was heterogeneity amongst those 5 studies, and they were overall low quality. So the jury's still out with probiotics, but definitely not any compelling data. What about antidepressants and psychological therapies in IBS, something we do a lot of. So this was out of Alexander Ford's group, and they did this in preparation for the IBS monograph that was recently published in the Red Journal. And so they looked at tricyclic antidepressants compared to placebo, and they identified it as a risk ratio in terms of who was less likely to have IBS symptoms. So you can see for TCAs, they were much less likely to have symptoms compared to placebo. And the same thing with SSRIs. I will kind of caution that a couple of the studies seem to weight the SSRI group more, but overall there did seem to be favor in terms of TCA and SSRI improvements. The number needed to treat for this was actually quite low, 4.5 for TCAs and 5 for SSRIs. The number needed to harm, that's NNH, was 8.5 for TCA. So for every 8.5 patients who you start on a TCA, 1 has some sort of side effect. And so I think something that we all see and that we need to go kind of low and slow with these patients, but overall there can be some success with them. And when they looked at the alternative therapies like CBT, hypnotherapy, dynamic psychotherapy, they were more effective than controls. Exercise in IBS, this was another systematic review out of China, and they looked at 683 patients across 14 studies, and then looked at yoga, walking, aerobic exercise, Tai Chi. And basically there were benefits all across the board, but the data was poor, obviously not enough to do a meta-analysis with. So, one other thing to add to our armamentarium for functional bowel. For functional dyspepsia, we often use prokinetics. Currently, the ACG kind of recommends them third line for treatment of functional dyspepsia. So this was a systematic review and meta-analysis looking at some randomized controlled trials. They looked at all prokinetics, including erythromycin, metoclopramide, cisapride, domperidone, and a bunch of others. And you could see the overall number needed to treat was 7. But this was mainly weighted by cisapride, and when they removed cisapride, the number needed to treat was 12. So overall, a pretty low number needed to treat and much lower than PPIs, TCA, tricyclics, and other treatments for functional dyspepsia. The interesting thing is that we typically think of prokinetics for the postprandial distress subtype of functional dyspepsia, but there appeared to be benefits in both epigastric pain syndrome and PDS. So it doesn't matter what subtype of functional dyspepsia, there appeared to be some improvement. And overall, no major improvement in quality of life. So based on this meta-analysis, prokinetics can be effective for functional dyspepsia, but still not first or second line therapy. So gut microbiota, something that I think Dr. Chopra is going to talk about later, but obviously very important. This was a pretty well done study out of Gastro earlier this year that looked at gut microbiota in IBS. And I'm not going to go into it in much detail because there really wasn't that much that was found with this. Basically, they looked at a bunch of trials and included 24 in their study. But the majority of them showed no pattern in terms of gut bacteria and IBS symptoms when compared to controls. The only findings that they found were in a bifidobacterium and fecalibacterium. There seemed to be lower proportions of this, but in IBS symptoms, there seemed to be higher in these phyla. And so definitely not anything we can take home. And the other challenge with this is mainly stool bacteria, so it doesn't really tell us much about overall small intestinal bacteria, and there was a lot of heterogeneity in terms of how they evaluated the stool microbiota. So some trends, but still obviously a lot more work that needs to be done in this area. Linaclotide is something that's been around quite a bit, but this was something that looked at some actual motility data in terms of smart pill and its effect in IBS with constipation. So as we all know, linaclotide is approved for IBS-C and chronic idiopathic constipation. It's an agonist for guanylate cyclase C, and it increases cyclic GMP concentration. And this has effects on CFTR ion channel, which secretes chloride and bicarbonate. It's also thought that intracellular movement of cyclic GMP may modulate visceral hypersensitivity. So this was a small study looking at 16 patients with IBS-C who were on higher dose linaclotide, 290 micrograms. A wireless motility capsule was performed at baseline and after 28 days. And just to give you some familiarity, the green line is pH, the red is pressure measurements, and there's also temperature, which you can't see, which is, I think, on this y-axis. But with the drop in pH, you have the gastric emptying time, and then slowly increases in the small intestine, and then you get a little more drop as you cross the ileocecal junction. And then upon exit of the capsule, you are able to calculate the colonic transit time. So in this case, they looked at linaclotide and its effect on cecal fermentation. They looked at reduced pH across the ileocecal junction as a marker for that fermentation. An improvement in cecal fermentation was associated with an improvement in symptoms. It also improved cecal transit time. So it seems like linaclotide, in addition to overall improving motility across the colon, there was improvement in cecal fermentation and symptoms. There was not any improvement in gastric emptying time or small bowel transit time. So this effect seems to be mainly limited to the colon as well. And I didn't include it, but a follow-up study on this should be noted that in Japan, they looked at higher dose linaclotide, 0.5 milligrams, so almost double the higher dose as a safe and efficacious treatment in constipation in Japanese patients. So there may be more range to play with this going forward as well. Switching back to gastroparesis, we have very limited options in terms of treatment. We do have stimulators and other treatments, but we haven't really looked at gastric peroral endoscopic pyloromyotomy or GPOEM in detail. So this was a study looking at GPOEM as a potential treatment option for patients with gastroparesis. So this was a retrospective study of 30 patients who underwent GPOEM for gastroparesis, and they were all comers. They didn't look at pylorospasm or other features. It was basically anyone who failed medical treatment. After GPOEM, 80% had improvement in their cardinal symptom index scores. There was also improvement in quality of life. And after 18 months, there was much less hospitalizations and ED visits. So this is just a little graph looking at how GPOEM is performed. A mucosotomy is performed about 5 centimeters proximal to the pylorus, and then a tunnel is made, and then myotomy of the circular fibers of the pylorus is performed, and then the defect is usually closed with either clips or an oversuturing device. So this is something that's done at a lot of tertiary centers currently, and maybe an option going forward for some of our gastroparesis patients. You could see that in pre-GPOEM compared to post-GPOEM, there was actually quite rapid improvement in symptoms, both in the overall gastroparesis symptom index, as well as nausea, early satiety, and bloating. And this seems to carry out over 18 months. So even though there's rapid improvement, there didn't seem to be any decay of symptoms over the duration of the study. Pneumatic dilation is something that we don't do very often in achalasia anymore. It's pretty much Heller myotomy or POEM. But I think some of us have moved away from it because of concerns with safety and efficacy. And so this was a nice systematic review and meta-analysis looking at the efficacy and safety of pneumatic dilation. And they looked at 10 studies with over 600 patients. And the interesting thing was there was a high success rate, 81 and 79% for the lower pneumatic dilation at 30 and 35 millimeters, and a pretty high success rate at 90% at 40. And this is all comers. This isn't based on achalasia subtype. The other interesting thing is the perforation rate was actually pretty low, and it was most commonly with the first dilation. And what they found was that graded dilation was safer. So even in a patient who did not have symptomatic improvement at 30 millimeters, if you did graded dilation and brought them back electively and went to 35 and subsequently 40, there was even a lower rate of perforation. So not something we do very often, but pneumatic dilation is still pretty safe overall and may have some benefit in select patients. I included this study just because I thought it was quite interesting. So metformin is a little bit of a wonder drug now. It obviously has good data in diabetes and polycystic ovarian syndrome, but it's being used in certain cancer treatments. It's being studied now in longevity. It's shown to improve overall life survival, and now it's being studied in IBS. And so as you guys are aware, there's a lot of factors involved with IBS, but one of the factors is a barrier dysfunction, cell permeability, and mast cell activation. And so they looked at IBS in rat models where IBS was induced in rat babies, and they checked, sad I know, but they checked these poor little rat babies for visceral hypersensitivity by colonic distension, and then they did biopsies of their colon to look at tight cell junction dilation and mast cell activation. And what they found was that there was reduced visceral hypersensitivity, and overall inhibition of tight cell junction dilation and mast cell activation in the rats that were pre-treated with metformin. So obviously the next phase would be a human study, but this may be a potential therapeutic option for a select group of IBS patients. So I'm going to go quickly over this. So long-term outcome of anal rectal biofeedback for treatment of fecal incontinence. So we always recommend anal rectal biofeedback for FI, but how effective is it? Well, the good news is it's pretty effective. 54% had overall improvement at 7 years, and that was defined as 50% reduction in fecal incontinence episodes. Unfortunately, that did not equate with quality of life. So even though there was improvement in fecal incontinence, this did not equate with quality of life. The other important factor was that the improvement was typically seen early. So they did weekly biofeedback over 6 weeks in this group. And so with the first kind of set of biofeedback, if there was not improvement, the patients moved on to surgery or other treatment options. So the patients who tend to do better improve quite quickly. So I think that's something that's important to take away from this study as well. Botox and hypercontractile esophagus, very quickly. They looked at 13 patients with hypercontractile esophageal motility, and this include spasm, nutcracker, and type 3 achalasia when compared to a sham procedure. And basically, there was no improvement at 3 months, and this included even in those patients who received additional Botox injections. There was a trend towards improvement at 12 months, but this was independent of Botox. So it may be that these patients were just kind of getting better on their own and kind of burning out their esophagus. So overall, very small study and more work needs to be done, but Botox does not seem to be a good long-term option for these patients. And then lastly, SIBO is a big kind of topic amongst patients these days, and we do a lot of lactulose and glucose breath testing, but is it a good kind of marker for bacterial overgrowth in the jejunum? So this looked at glucose-based hydrogen and methane testing and compared it to jejunal aspirates that were cultured as well as PCR. And what they found was that hydrogen and methane levels did not correlate with higher colony counts. But hydrogen and methane levels did correlate with lower viability of jejunal bacteria. So although a positive glucose breath test may not mean SIBO, it may mean there are alterations in permeability and overall gut bacteria diversity in the small intestine. So just some quick take-home facts. Chronic opioids do affect high-resolution manometry. Cannabinoids are associated with worrisome symptoms in patients with nausea and vomiting, despite their perception of overall improvement. Antidepressants, psychologic therapies, and exercise improve IBS, whereas probiotics may not. More research needs to be done in that area. Prokinetics improve functional dyspepsia, but are third or fourth line treatments. GPOM may be useful in gastroparesis going forward. Graded pneumatic dilation is safe and effective in achalasia. And biofeedback has good long-term improvement in patients with fecal incontinence. Questions?